Our next speaker is Dr. Mufaddar Al-Aithan. He is consultant rheumatologist at Prince Sultan Military Medical City in Riyadh. He participated in the quality committee and academic activities within his hospital. Dr. Mufaddal holds special interest in immunology and autoimmunity. You are more than welcome, Dr. Mufaddal.
Thank you very much. So before I start, I'd like to thank the chairpersons for the session, and would like to thank the Saudi Society for putting this very interesting conference all together, and headed by Dr. Hanan Al-Rayes. I'm going to talk about a topic that I truly like, and we're going to discuss a few updates about the management of inflammatory myositis. Okay, so sorry for that. I've got nothing to disclose. You probably know this. Myositis is a systemic autoimmune disease characterized by weakness, fatigue, and loss of muscle power. It is more common in females, and it is very, very rare disorder. So this makes it very difficult to be managed because of the rarity of the disorder. So steroids have been the mainstay of the treatment of myositis for a very long time, and on the long run, this tends to be problematic. Methotrexate, Imuran are usually used as first-line immune suppression, and beyond that, it's really difficult to decide which way to go because of very few RCTs, very low level of evidence. So we aim to review more recent publications, at least for the past 3 years or so. So first of all, this is about 3 years ago, there's a paper published about the use of mycophenolate mofetil in a series of 20 adult patients who had refractory myositis. And the way they defined refractoriness was having active manifestations despite using at least 2 immune suppressants, or they were unable to reduce their steroid doses. So MMF was used either as an add-on to their therapy or as a replacement for their immune suppression. So you can see in this slide their baseline immune suppression. So for example, the first patient was on cyclosporin, and MMF was added to her. And the second patient was on azathioprine, and MMF was replacing azathioprine, and so on. So up to 2 grams of MMF were used, and they were generally well tolerated, and this had resulted in a significant steroid reduction, and they could taper down their steroids from 15 to 5 milligrams, which is very good for the patients, and a total of 4 patients had achieved complete remission of their disease with MMF. 14 patients could reduce their steroid dose by half. However, 3 patients were intolerant. Unfortunately, this paper does not report exactly which manifestation had responded by what. So this was as far as we could get from that publication. So second is a very interesting paper that looked retrospectively to analyze patients who were on MMF and had a calcineurin inhibitor added. So the question was, does adding calcineurin inhibitor to a backbone of MMF improve the response in myositis or not? So they found 12 patients who had been on MMF alone, and they compared them to 7 patients who had MMF plus a calcineurin inhibitor. And those who were on MMF therapy did not reduce their CK level significantly. However, there was a borderline significant reduction of CK by combining MMF with a calcineurin inhibitor. Interestingly, there was no difference in the forced viral capacity. There was no difference in CT scan, and both groups reduced the steroids significantly. So adding a calcineurin inhibitor may help the muscle disease a little bit. So this is what we get from this one. So next is a prospective study that looked into adding tacrolimus to patients with myositis and whether or not did it make a difference in their survival. So they've used tacrolimus by starting off 0.075 milligrams per kilogram per day in divided doses, and then it was adjusted to achieve a trough level of 5 to 10 nanograms per ml. So they had about 25 patients who received tacrolimus therapy, and they compared them to a group of historical controls, and that was made of 16 patients with myositis. So looking at the mortality at 52 weeks, we have 3 patients in the tacrolimus arm that have died compared to 4 patients in the controls that have died, which might have some survival benefit, but the number is very small. However, interestingly, the progression-free survival was 10% better in the tacrolimus arm, and the average dose used was 3 to 4 milligrams per day. So this might have improved their symptoms during the period they survived. So next I'm going to talk about Ritoximab. So Ritoximab has been very interesting area in myositis in general. So this publication looked into registry data into myositis patients, whether Ritoximab was effective or not. So they divided the patients into either having a synthetase antibody positive or they were synthetase negative. And then they looked at how they responded to Ritoximab. So they've got 27 patients who had a synthetase and 16 patients who were antibody negative. Now, up to half of these patients had failed at least 2 immune suppressants. So they were considerably refractory cases. Now, both groups showed significant reduction or significant response to Ritoximab, and they've used an outcome measure in myositis, which is the ACR-EULAR response, which is a complicated set of multiple criteria, including the muscle power, muscle enzymes, fatigue, etc., etc. So they've achieved a 78% response in the antibody positive and a 50% response in the antibody negative group. So both groups responded. However, it was quite better in those who had a synthetase. Now, as they extended the period, or they received several cycles of Ritoximab, those in the synthetase negative group had gained more responders, but remained to be less than those with synthetase positive, and only those with antibody positive myositis were able to reduce their steroids significantly. Now, this is a series of 3 cases of necrotizing autoimmune myositis who had history of statin use and tested positive for HMG-CR, and they had a biopsy consistent with the necrotizing myositis and failed multiple lines of medications, including steroids, methotrexate, cyclosporin, and even plasma exchange. So they added Ritoximab for these patients, and after that they've responded with a reduction of their CK level with an average of 100 to 300, which is considered great for these patients. They remained with mild weakness. However, interestingly, in 2 patients out of these 3, the titer of the HMG-CR antibodies turned a negative or normalized, which is an interesting phenomena. Whether this corresponds to a clinical response or not is a question. Now, this is, I think, one of the most interesting publications that looked into combining aggressive early therapy in patients with MDA5 positive, rapidly progressive pneumonitis, and this was compared to the usual step-up approach that people use in treating these patients. So in patients with MDA5 positive pneumonitis, they were treated from the beginning with a combination of steroids, cyclophosphamide, anacalcinurin or FK, and a plasma exchange altogether, and compare them to a group of historical controls that had received the business as usual therapy. Now, the combination therapy consisted of steroids at a high dose, and then it was tapered by 10% every 2 weeks, and then every 4 weeks after achieving 30 milligrams. And FK was used targeting a trough level of 10 to 12 nanograms per ml, which is higher than the previously used or the previous publication. Cyclophosphamide, interestingly, was used with a dose of 500, aiming to 1 gram per meter square bi-weekly for 6 doses, and after the 6 doses, they extended further to 10 to 15 doses, but they lengthened the duration or the dosing interval up to 8 weeks. And then plasmapheresis was used when the patients had not responded or flared, and they've used anywhere between 1 to 3 sessions for up to 13 weeks. So this is a very, very aggressive early therapy. Now, in this group of patients, they looked actively for CMV antigenemia, and whenever they had a positive test, they would be treated immediately to suppress the CMV antigenemia, and they were on Septrin prophylaxis for PCP pneumonia. Okay, so they've got 29 patients in the combination group and 2 dropped out. They had 27 completed the 52 weeks, and this was compared to historical group A that had the business as usual step-up therapy, and historical group B that had the combination therapy without the plasmapheresis. So we would know whether this had added any benefit to these patients or not. So they've looked at the mortality at 6 months as a primary outcome, and then at 1 year as a secondary outcome with a set of lung functions and CT scan scores and so on. Now, a little bit descriptive about the patients. They've, in general, received similar or comparable cumulative doses for cyclophosphamide, and the initial combination group, interestingly, had a much earlier cyclophosphamide compared to the business as usual group, and the difference was up to 20 days. So the demographics did differ very slightly between the 2 groups of patients, where the combination had a little bit higher DELCO. The historical controls had better vital capacities, and they were more unclassifiable ILDs in the combination group. Now you look at the survival and you see very interesting, at 6 months, 89% of the early combination group survived, and at 12 months, 85% survived, and there's a massive difference of survival benefit compared to the business as usual or the historical control groups, where they've survived around 30% only. And interestingly, the survivors had no oxygen requirement by the end of the therapy, or they were not dependent on oxygen. Now, looking at this, you see a reduction in their airspace consolidation and ground glass opacities or attenuations on the CT scan, and interestingly, you see a significant reduction of their MDA5 titers along with the therapy. Now, plasmapheresis added about 10% gain in mortality benefit. So comparing the plasmapheresis group to those that did not receive plasmapheresis, there was about 10% or so gain at 6 and 12 months in mortality. So those patients that have died during this study had more cutaneous ulcers at the baseline and higher ferritin, CRP, and LDH at baseline compared to those who have survived. And interestingly, respiratory functions and the time between disease onset and the treatment did not differ between the survivors and the deceased ones. So CMV reactivation was more frequent in the early combination group. However, it was treated rapidly, and bacterial infections and others were quite comparable, and generally the treatment was tolerated well. Now we move to a more interesting area of myositis, which is the use of JAK inhibitors. And this had gained interest after a report of a patient who had myelofibrosis with myositis that responded to risolitinib in both areas. So this had led to a cascade of publications about tofacitinib use in myositis, and this is an interesting case of a 55-year-old lady who had anti-TIF gamma positive myositis and had a classical skin rash, weakness, and failed multiple lines of treatment, you name it. So she had a flare of inflammatory arthritis for which tofacitinib was introduced, and interestingly, after 2 months, the arthritis had gone along with the rash, and later on the power improved to become 5/5, and within 6 months, she's free of steroids. Now, more cases or more interesting cases had been published afterwards. So this is a patient who had a flare of myositis that had disabling calcinosis and arthritis with myositis and failed treatments. So she was started on tofacitinib, and you can see that in the upper pictures, you can see that the calcinosis before the treatment and the calcinosis at 16 weeks post tofacitinib with very nice reduction of the calcinosis there. And this was reported to be even improved further as they extended the therapy. Now, another MDA5 pneumonitis myositis that had failed multiple lines of treatment and responded to ritoximab cyclosporin but remained bound to oxygen and flared afterwards, so started as tofacitinib, sort of a last resort therapy, and after that she improved, free of oxygen, and you can see the CT scan after tofacitinib. There was a nice resolution of the ground glass opacities after tofacitinib therapy, and you can see, interestingly, resolution or reduction of the abdominal wall calcinosis and improvement in the vital capacities and the DELCO after tofacitinib therapy. Now, this is another publication about a very aggressive presentation of fulminant pneumonitis and synthetase syndrome. The patient rapidly deteriorated to be mechanically ventilated and then bound to ECMO. So after ECMO, he was started on pulse and tacrolimus with no response, but after adding tofacitinib, he was weaned off ECMO, extubated and discharged from the ICU, and you can see the CT scan downstairs, and you can see a very, very nice resolution of the ground glass opacities on his CT scan. Now, another one with MDA5 myositis that had flared with pneumonitis and rashes, and you can see resolution of the skin rashes, the periungual erythema and the ulcers, as well as the pneumonitis. And another patient with polymyositis that had flared with pure weakness and lost response to initial ritoximab, and then she improved on tofacitinib with the MRI showing resolution of inflammation, as you can see in the fat suppressed sequence images. Now, this was an interesting publication about a review of biologic therapy in myositis. So ritoximab, I think we talked about it, and it had an overall positive effect in myositis patients, whether antibody positive or negative, and the steroid reduction was significant only in those with a synthetase. Now, anti-TNFs, they had very contradictory data, and they had a concern for a negative outcome and cases reported for having TNF-induced myositis, so this did not become a favorable area of therapy. But there were some case reports of positive outcome. Abatacept, interestingly, had been studied in a group of 20 patients who had not responded to a single immune suppressant and steroids for at least 3 months, and then 50% of them responded to abatacept, and tocilizumab had very small or few case reports in treating myositis. This was my talk, and thank you very much.